Welcome to the So Why podcast with Step Care Solutions. So why are we excited about Step Care 2.0? SC 2.0 is an innovative and transformative model for mental health and substance use healthcare that leverages collaborative efforts and technology to transform systems for better access and outcomes. And SCS exists to help organizations and communities reframe, rethink, and redesign the delivery of mental health services through flexible, open access, recovery-focused approaches. On this podcast, we explore issues and challenges, as well as ideas and solutions around how to create person-centric systems that are holistic, accommodating, and thoughtful. My name is Shauna Cronin, Vice President, Strategic Partnerships and Communications at Step Care Solutions, and I will be your host for this episode. I am hosting conversations with leaders and experts at national organizations focused on rethinking Canada's mental health and substance use health systems. My guest on this episode is SM Sansouci, National Government Relations Lead at the Canadian Mental Health Association. SM is the Government Relations Lead with CMHA's national office. Her role is to influence federal public policy. This entails everything from organizing Hill Days, ghostwriting op-eds, publishing research, and participating at consultative tables where decisions are being shaped. Unlike many lobbyists who come from political staff roles, SM spent the first decade of her career as a researcher in the federal public service, working on the development of legislative and public programs. She brings that insider's knowledge of how government decisions are made to nonprofit advocacy, where over the past 10 years, her work has helped strengthen early program iterations of the National Housing Strategy, cement a legislative right to housing, and secure the creation of a $500 million youth mental health fund. The Canadian Mental Health Association is a nonprofit charitable organization and the largest provider of frontline, out-of-hospital mental health and addiction services in Canada, delivering care in more than 330 communities across every province and Yukon. Founded in 1918, CMHA's origins started in advocacy to reform the inhumane treatment of individuals in psychiatric asylums and to address the mental health needs of soldiers returning from World War I. Today, local CMHAs deliver services ranging from early intervention, substance use and addictions treatment, housing supports, and crisis response, including as a network partner for the National 988 Suicide Crisis Helpline. CMHAs also contribute their expertise and knowledge to policy development and implementation for municipal, provincial, and federal governments. I'm excited to share my discussion with SM about rethinking mental health systems from a policy and partnership perspective. We also explore the role of government relations in system change, building shared intent between policy and practice, and how to create more thriving, integrated mental health systems and practice. Okay, so today we are going to talk a little bit about partnerships. We've been doing this series and having these conversations with folks across the country, trying to understand what makes good partnerships, how do we work well together, and today we're going to dive a little bit into how we bridge partnerships between community and government and intermediaries. So I'm really excited about our conversation. I want to start off with a question about how you see government relations. And maybe you can tell us a little bit about your work within the space, because I know you have a lot of expertise in this area. So how do you see government relations, not just as something that folks might associate with lobbying for funding, which is a way that we often think about it, but as a critical component of system design and a tool for building a shared intent with government?
Absolutely. And it's a really great starting question because I'm often asked, like, what do you actually do as a lobbyist, right? And I think a lot of that is flavored by what we see in movies and Hollywood. And it's a lot less boring and glamorous, or it's more boring and less glamorous, certainly than what's presented. And you have to have sort of a keen eye for identifying trends and understanding and seizing opportunities when they come up. But one thing that also is just subject matter expertise or understanding how to talk about policy in really accessible terms. And I think that that's a really key component to successful advocacy, is that idea that translating complex issues or challenges, like the healthcare system and how it works and interprovincial relations, isn't always straightforward to talk about. And so how do you translate that into something that's digestible, not just to decision makers, but also to the general public, right? Because advocacy doesn't happen in a vacuum. It happens with support from the grassroots. And so as a jumping point, I would say that having like a sound understanding about how to talk about issues in a less complex way is key to advocacy.
I love that, especially as a knowledge mobilizer. When we talk about the complexity of the system, I think it can feel overwhelming to all of us, even those of us that work in the system. And so being able to almost create a story, like what you're saying resonates with me in terms of telling a story and helping people create a clearer understanding of all of the different complex parts. So I really love that. And I wanted to sort of ask a bit of a follow-up, which is around that kind of shared vision, right? We talked about the intent of kind of building a shared intent. And can you share a little bit about how building those clearer stories or creating those clearer stories and understandings can help create that shared vision, or can it be a catalyst for it, I guess?
Absolutely. And I think as a starting point, especially on things like healthcare, it's not designed in a vacuum, right? There are, decision makers and folks like myself bureaucrats, public servants sitting very divorced from the actual service delivery, right? They're not on the ground, on the front lines delivering that. And so how do I, as someone who isn't delivering care, who doesn't see the day to day, how do I make a compelling advocacy movement, right? If I'm trying to run a campaign or I'm trying to affect policy. And on the flip side, how do people at the grassroots look at sort of like a monolith of a system and say, oh my God, I'm just one person. How do I possibly make change? And so there is a constant need, and this is something that is really embedded into what the work that the Canadian Mental Health Association does, is going back to peers and lived experience, right? And ensuring that the patient or the end user, the person who's navigating the system, is really central to how you run your advocacy. At the end of the day, I am only working on a sliver of a very large healthcare system, but healthcare is experienced as a whole, not necessarily as a sliver, right? And so you sort of have to say, okay, well, if, Jane is entering the system here and I'm working on this here, how does that coordinate with other aspects of the system? And are we ensuring that advocacy and policy sort of takes that more fulsome picture into consideration?
I love that, and really creating that sort of person-centered way of thinking about, as system transformers, we're doing one part, but this is often this whole person, it influences and affects their whole life. And that I think really grounds the work. And it makes me wonder a little bit about this drive for solutions that we have, right? We have a very tricky, complex sector where often the conversation becomes one of a deficit-based need. We need an influx of funding. That's often the area of focus. Yes. And while funding is part of that equation, can you tell me a little bit about how do we get a solutions-oriented narrative for our sector? And maybe how do we invite those that have lived experience into that solution-focused narrative? And also, how do we invite government into that?
I think the instinct when creating advocacy campaigns is to, I don't want to say go dark, but we definitely do take the deficit approach, right? And we often paint worst case scenarios, right? If there isn't funding, then this consequence is going to happen. And that's true. If there isn't funding for crisis care, or if there wasn't an extension of a certain program or service, then yes, there would be sometimes, in our world, devastating consequences to that. And so advocacy campaigns can sometimes take a bit of an alarmist approach. And that's sort of embedded as well into the urgency when you're doing advocacy, because most things are time limited, right? Like if you're trying to work into getting something into a budget, well, you only have a certain time frame in the year, if to get that conversation rolling, right? With decision makers, you can have a great lead up, but ultimately it's a very short time period where there's, concentrated, decision making shaping the budget. The other thing is with legislation, the same thing. Once legislation is on the floor to be debated, then there's a very short time window to try to influence that. And so we're always working in urgency, and we're always, I think, relying a little bit too much on the alarm of the situation. And so I think that it's about reframing a little bit the conversation, and thinking of it in collaborative terms, right? Because coming at it from a deficit, you're asking for something. You're asking for recognition. You're asking for investments. But instead, if you flip it and think of it in terms of everybody wants to get something out of this, right? The government has to think about how best are we using taxpayer dollars. And as advocates, we're thinking, how are we part of the government trying to address an issue, right? And I'll take something like wraparound supports, right? Like there's a lot of focus right now on affordable housing and ensuring that the government is building. Great. CMHA wants the same thing. We have a similar objective of wanting to address unsheltered homelessness. And so how are we working collaboratively to meet those needs, right? So CMHA is a partner to governments at all levels in addressing homelessness issues, in addressing the housing shortage, right? We, CMHA, are both landlords and we own housing units. So I think it's reframing it, and rather than coming to the government and saying we need something, it's also coming to the government and saying we're also here to help meet your objectives. And so that also flips the script on the power dynamic that is often embedded in advocacy, right? Government has something that we want. Well, government all has something that we're also able to offer, right? And those are those health outcomes. And so I think that it has a really strong starting point to move away from that reactionary or the tendency to go alarmist, and instead look at it as a collaboration.
I love that. And I think that resonates so strongly, especially kind of from my perspective, coming from Step Care Solutions, where we're trying to do system design work, where it's that piece around we need all of the different roles and all of the different facets that different players, actors bring, so that we actually can try to bring solutions to these very complex systemic issues. And to your point, even your example around housing, which I love, these are not homogenous issues with homogenous solutions. They're very dynamic, complex, ever changing. So we really need that collaborative kind of consortium approach to creating and influencing change.
And the knowledge expertise, right? Like organizations delivering care have an expertise, and we often have years of data to demonstrate the proof in the pudding, right? Yeah. To demonstrate that investing in these programs or services, or even that, one type of way of doing something for this community works a little bit better because of whatever reasons, right? And so, coming to the government with that knowledge base and recognizing yourself as an expert in that conversation, I think also helps to flip that power structure a little bit, right? Like we can't expect government to have expertise in everything. Like when I'm here, I'm talking about more a member of parliament. A member of parliament might have, really sound experience coming from small business, but they're not going to be experts in healthcare. So recognize yourself as an expert when you're doing that advocacy, and come prepared to explain things, as we sort of started, at the beginning of this conversation, in very simple terms. So I think that those two things are really important to keep in mind in building that relationship with governments.
I love that sort of ownership of expertise from where you stand and where you come, because that's also a huge factor in helping government make informed decisions.
Absolutely.
Which is where we want to equip our government to be able
Mm-hmm.
to operate, is in that space of informed decision making.
Mm-hmm.
So I'm gonna kind of layer in this knowledge to practice piece that we've kind of been talking about, this knowledge mobilization, from a community level, because I think also, for folks that maybe don't work in the system in the same way, something like mental health or substance use health or health generally, that seems like a huge gap between policy that's made and what's happening in communities. So can you talk a little bit about how we try to lessen that gap when we do system work and advocacy and working with government? And what does that policy to practice loop look like? How do we influence it, and how does it happen?
Well, I mean, we talked a little bit about grassroots, right? And ultimately, it certainly helps that community is embedded in the community mental health that we're delivering. So we have touch points with people who are using our services. And so right then and there, it's that feedback is a lot easier. So when I work at the federal level, so I'm a federal lobbyist. I don't touch provincial work. I don't touch municipal work. However, that work very much influences what I'm doing at the federal level. And so as a starting point, before any conversation that I have with either an individual member of parliament, a cabinet minister, or senior decision makers within the federal service, I'm going back to the local CMHAs who are doing that delivery, and I'm, asking them to elaborate or clarify, or explain a challenge and how they're either addressing it or where they see, solutions. And so, for instance, CMHA is often involved, and I'm often involved in consultative tables, right? Very, very, process heavy, right? Whether that's creating a new service or program, trying to amend legislation that is extremely process oriented. And so I will go back to my local CMHAs and I'm going to say, all right, this is the issue that the government is hoping to address. How have you seen it play out on the ground? How are your clients seeing this as a challenge for them, right? Maybe it's an issue, for instance, of the referral program. Maybe it's an issue of the access point and navigation isn't very clear. And so I'm able to take all this information back, and I'm an information hoarder, right? I love notes and I love reading research because that is my background. But I want to take that and ensure that is embedded in the conversations that I then have. So I see myself as a bit of a flow through of that information, right? And where possible, that I'm not necessarily the person doing the speaking, right? Is there an opportunity to say, I'm not the best placed person to talk to, or it should be me and a local CMHA that comes to that table, right? So also using my privilege to open up spaces for locals who have the subject matter expertise. I have it maybe on the research and the data, but they have it on the service delivery. So ensuring that there are opportunities, that their voices are heard in an indirect way through me as a flow through, or directly by saying, this is the person who should be at the table.
This is making me think as well about integrated or connected issues. And are there ways, because you spoke about those limited spaces, like the policy window or being on the floor, legislative, right? That you have these small windows. Is there thinking and strategy behind trying to integrate issues, or is it best to go with a single issue, especially when you're trying to bring people to be able to speak about their experiences? How does that work from a strategy or an advocacy strategy perspective?
It's going to be a very unsatisfactory answer because it's context, right? It really, really depends on who you're speaking with, what the issue is, what is the environment or the context, right? Like, because sometimes government has themselves a very short window to try to get something out, whether that is because a program needs to be rolled out because they've set themselves a deadline, or there's, like you said, a piece of legislation that needs to roll out. And so I can't necessarily say that there's one way better or not to roll that out. It's really context dependent.
Well, we love to say context matters when we do system work. So it sounds like context matters when you're doing advocacy work as well, which
Absolutely.
makes good sense.
But there is still an opportunity, right? I don't want to make it sound like we're reactive. Like something happens, we're asked to, consult, or there's a lot of groundwork that we do. And I think I spoke a little bit about it before, about identifying trends, right? Like we can see, a few months ahead of time and say, well, even a year sometimes ahead of time and saying, well, we can sort of see affordability issues, for instance. Right. In our current context, right? Affordability issues are of importance, not just to decision makers wanting to address affordability and the cost of living, but also for Canadians who are experiencing that pinch, right? And how does that play out in mental health? Can we say, well, is it a question to ask and say, will Canadians who have to pay out of pocket for mental health services simply forego those services because they are not in a financial position to be able to afford them? And so how do we, recognizing that that's a possibility or a possible thing coming up, how do we address that, right? So how do we go back and say to our local CMHAs and also ask them, what trends are you experiencing that we might not feel at the federal level yet, but it's coming? Yeah. And so you can build advocacy around that, right? And that definitely forms part of any advocacy campaign building. You don't have a crystal ball. You can't always predict the future, but you can at least do some scenario planning. And so that is something that is embedded into any advocacy that we're working on, whether that is a government submission to a large scale public facing campaign. So I definitely don't want to make it sound like we're always in a reaction mode, right? I mean, good advocacy is proactive.
It sounds like it's proactive and timely is what I'm taking from what you're sharing.
Yeah.
So it's making me think a little bit too about, we talk a lot about mental health, as almost like it's this object or this item. And I'm curious a little bit about how we build partnerships and think about system design if we are positioning mental health as a public good, a public right. You gave a beautiful example about, would someone forgo this if they don't have the ability to pay? And so how do we think about partnerships if we understand mental health to be a public good or a human right? And how do we help governments and others commit to that thinking or lean into that thinking, and then have that shared purpose and momentum kind of around the human right to mental health or mental health as a Canadian public good?
One of the tricky issues is that most mental health care services and addiction care services and even suicide prevention care services are not fundamentally integrated into our health ecosystem that is publicly covered, right? Most mental health care services are through employer benefits or through community services like CMHA, or you pay out of pocket. And so right there is a challenge and a limitation that separates the public healthcare system from mental health services and addiction health services. So you're already starting on a bit of wonky footing, right? And so part of my job is, how do I unravel that logic a little bit, right? Because we all recognize the importance of having good mental health. We can speak until we are blue in the face about its role in, economic productivity, which is, a very timely subject. We can talk about it in terms of affordability, that people cannot afford about it, which is also a timely subject. But ultimately, if the system is built in such a way that deprioritizes mental health care, then it is very difficult to sort of surmount that. And so one of the things that I've been giving a lot of care and thought to is how we actually, the language that we use and how we actually talk about mental health. And it's often in terms of programming, right? Whereas when we talk about emergency care or hospital care, it's in terms of services. And I think that that language is very powerful because mental health care programming seems more like a ancillary social good versus an essential service. You wouldn't cut an essential service, right? We couldn't possibly imagine the government saying, well, we are in a moment of austerity and therefore we're going to cut, ambulance services by half, right? That would be unimaginable that we would do that. But we tolerate cuts to mental health because it's seen as either a nice to have or seen as, well, the responsibility of employers to cover through benefits. And so how do we reframe mental health as an essential service? And I think that that's a very strong starting point because we don't have the starting point in legislation, right? Mental health care isn't covered under the Canada Health Act the same way that physical health is. And so you're already coming at it from a bit of a deficit question. And so I think as a starting point, it's maybe reframing how we talk about mental health, right? And not permitting ourselves to talk about it in softer terms, right? And talking about it as an absolute necessity for individuals and for our society.
I think that's such a powerful way to reframe this piece. And I think you're right, especially now when we have conversations about geopolitical and socioeconomic complexity. And definitely these conversations are grounded in these not only national, global sentiments of austerity.
Yeah.
And that's where we get into the conversations about, well, what needs to go? What's a nice to have, to your point? And you spoke a little bit about the data is there to demonstrate the business case for investment in mental health. But then that's part of coming back to our earlier conversation, that story and that narrative and making things really clear and concise. And one thing that I think we are getting better at in alignment with your essential service point, but still have a bit of a way to go, is really articulating the direct output of investment in mental health and substance use health. So I think that's such an astute point. And it feeds very nicely into my last sort of formal question for you. This wasn't a setup question, I promise. No, maybe it was, I don't know. But what's the one legislative or policy change that you would make right now to accelerate the shift from this sort of reactive or crisis driven system? We talked about like a bit of a resource scarcity or austerity mindset system to one that really enables people to flourish.
I mean, the pie in the sky, the thing that ultimately I think anybody working in the mental health care space would say is a legislative protection for mental health, right? So the Canada Health Act, for instance, ought to include mental health and addiction healthcare. So that would be the ultimate. And there is a private member's bill working its way right now that we're going to be obviously keeping our eye on and hoping that it gets the time it deserves to be debated, right? And ultimately, the fingers crossed that it actually passes. But I think in a more timely conversation, and I don't want to sound like I'm completely being a hypocrite about what I said about being an alarmist, but one thing that we're quite concerned about is the sunsetting of the bilateral agreements that were signed in 2017. So a little bit of a primer for those who might not be as invested into the minutia of how healthcare is funded. In 2017, there were 10-year bilateral agreements signed between the federal government and provinces and territories. And that provided funding specifically for mental health and addiction healthcare services. And these bilateral agreements provided about $600 million annually. And that is going to expire in March of 2027. So when we talk about understanding what the window is going to be in the future, right? This is a perfect example of saying, okay, there's a funding cliff coming, right? And it involves money between federal government and the provinces, and it will play out ultimately in municipalities. It will be municipalities that will not have the funding to be able to run mental health services, to provide those wraparound supports that people rely on. And so one of the things that the Canadian Mental Health Association is going to be working on is a campaign to bring to light and try to make this sort of very process-oriented, kind of boring subject about bilateral agreements into an accessible campaign around the loss of community services that might come. And so this is where we're at right now, at least at the time of recording this podcast episode, is how are we thinking through those same dynamics that we talked about earlier on in our conversation? How is CMHA and other community partners coming as a collaborator, not from a deficit model saying we need this investment to continue, which we absolutely do, and that will be fundamental to the ask of this campaign. But we also need to say, and these are, for instance, some of the outcomes that came with steady 10 years funding. This is what is at risk, but this is also what you made possible. And so that one thing that we're hoping to change, or I possibly a bit of a cheat because now I'm saying two. One is that piece of legislation, but the second is also that bilateral funding is extended.
I think that hearing you talk about, it's almost like inviting people in to celebrate the success of what has been achieved. And, we often say, oh, you don't want to feel proud. You don't want to have pride, but there's a sense of pride, in what I'm hearing you say, that a lot of work has happened from the government, from community partners, from intermediaries, such as our organizations, from communities, from lived experts, to build a system that is responding. We've had successes in how we've moved forward in mental health and substance use health over the last couple of decades, I'd say, in a pretty significant way. And I hear you saying, keep that going.
Yes, absolutely.
That's going. Let's keep it going. And we don't want to have to operate from an even further deficit place in a couple of years to come. And it makes me think a lot about young people right now, and a lot of what we've heard from young people, and the importance of investing and understanding mental health and substance use health as really a cornerstone or a pillar to what their future needs will be. And so I think that continued investment and that continued momentum around what's been built already makes a lot of sense.
And also, we've changed in the last 10 years how we address and think about and talk about mental health, right?
Very true.
Going back to a little bit of our conversation around language, right? Like, we've become accustomed to the openness and destigmatization, not entirely there yet, but, we think of large campaigns like, CMHA's Mental Health Week, right? This has been going on for 75 plus years, but the conversation and the willingness of everyday Canadians to say, yeah, this has been my experience, right? There's a lot less shame and stigma to talk about mental health. And that plays a very large part in then being able to go to government and say, this is an important piece of public good. This is an important piece of healthcare. If everyday people are not talking about it, then it's a lot easier to shut it out, right? You're not going to miss something if nobody talks about it. But if people are demanding and saying, no, we're not going to tolerate wait lists. We're not going to tolerate that we have to not get care and be unwell and continue in our jobs and continue as parents completely at a loss of how to help our children or how to help ourselves when we're struggling, right? If we stop and say, we're not going to tolerate that anymore, then governments have to be an equal partner representing us. We live in a democracy, right? At the end of the day, they are representing their constituencies. And so if constituencies and everyday Canadians are saying, this is something that we value and that should not be removed in a situation of austerity, then government's going to rebalance maybe where else can we find, in their words, find efficiencies, right? And so I think that's an important part to consider is the language and how we talk about and when we talk about mental health and addiction care.
Definitely. And I think the piece that you're speaking to that's really resonating with me as well is for everybody to be talking about it, all of that work around trying to destigmatize mental health, addiction, substance use health, that has been, I think, a huge mobilizer for people to care beyond themselves, right?
Yes,
just because I'm not experiencing something right now, there's more recognition in society now, I think, that I may or I have, or someone I care about could, or someone in my community could, and that matters. Other people's experiences of being well matter as well. So, and that there's a nice community component to that makes me excited. Makes me excited for the future, and I think is going to be very important for Canadians going forward. So I love that. I love what you're sharing there. So we're kind of coming to the end of our time, and I just want to ask you if there's any last thoughts to share with our podcast participants.
Well, again, swearing that this isn't a setup, but sort of your concluding sort of ruminations is perfect, because the campaign that we're going to be running for the bilateral agreements is called Someone's Someone. And it really does, again,
it wasn't set up.
I know, not a setup. So it's really great. But this exact idea, right, that we individually face mental health challenges, right? And that's a very individual struggle or challenge. But collectively, we love, our children, our neighbors, our community members, our partner, our spouses, and we want them to be well. And so everybody is someone's someone. And that is, again, changing and reframing the language around mental health. So the thing that I would like people to take away is, again, get involved, right? If you're talking about the issue, then government is going to pay attention to the issue because government represents you. That is their job, is to represent you in a democracy. And if you say mental health is a public good that should never be taken away or sacrificed, then they're going to respond. And so within that Someone's Someone campaign, there's going to be opportunities to have more grassroots individual actions and individual participation. And so I would say, whether it's, this campaign or other campaigns, speak to your representatives, right? Let them know that this is an issue that matters to you or matters to your someone's someone. So perfect, shameless plug. That was...
Well,
we'll leave that there.
SM, thank you for being my someone today for this podcast. It was lovely to have you, and just a great conversation. And thanks for sharing some of your expertise and your insights with us.
Likewise, I love any opportunity that I can have to connect with you. So this was a very welcomed opportunity, and hopefully there'll be more.
Yes. Thanks. Our guest today was SM Sansouci, National Government Relations Lead at the Canadian Mental Health Association. For more on the work of CMHA in more than 300 communities across Canada and other key items of discussion from this episode, please find links in our show notes. I'm Shauna Cronin, Vice President, Strategic Partnerships and Communications at Step Care Solutions. Thank you for joining us on this episode of the So Why podcast.